and grazie a
I want to thank Enzo Cernicola for his great invitation. It is always a pleasure to be here. I've been attending SICSSO for many years. I'm just going to switch to English because it is slightly better than my Italian.
So these are my financial disclosures. None of them is related with this particular talk. So as it has been previously mentioned, first of all, late endothelial failure is the commonest cause for reintervention after full-thickness corneal transplantation. We know that. Together with a higher risk of immunological rejection, a new full-thickness technique is obviously associated with its classical comorbidities, most of them related with being an open sky technique, and an unstable and unpredictable astigmatism and slow visual recovery. Of course, conceptually, EK techniques have the theoretical advantage of a lower risk of immunological rejection and lower perioperative risk and a low surgical induced astigmatism with a quicker visual recovery. And that's why most of us are using these techniques. As you can see, if you take a look to the previous reports on using EK after failed PK. In fact, there are not too many papers. Most of them until late 2016, the most commonly used technique was the SICSSO for this EK after PK, but obviously in late 16 and 17, new articles are being published in using DMEK for these situations. This article published in Griffiths, where they were still afraid of the capability of the DMEK in working on that, so they use it in 19 eyes, but with a limited visual potential. And, but the group of Levy use it in 11 eyes with absolutely normal potential. And we submitted the work that I will present to you for cornea last year. So these are a group of 26 eyes, 14 male and 12 female, with late endothelial failure after their first PK. Only one of this particular group had 2 failed previous PKs. 12 eyes with a previous history of 1 or more episodes of graft rejection. And originally, this is the distribution: 7 keratoconus, PBK, 11 eyes, ABK, 1 eye, and post-infectious keratitis scar in 4 eyes, Fuchs in 1 eye, and post-traumatic corneal bone in 2 eyes. So it was used the standard surgical technique. The only particularity in this group, and this is my standard approach for this particular group, although I am exploring, I will tell you at the end, another small step, but basically it's without host descematolexis. So this is the standard techniques. This is not a need, but regularly I like to debride the epithelium that is loose and leave the epithelium that is tight adhered. I think that first of all, my visualization during the surgery is better, but I think that the epithelialization is also quicker as long as you obviously protect during the first post-op days. Well, the technique is more or less the same. As Mark mentioned, each one of us has his own small tricks. So, but basically, what we all pretend is more or less the same in the quicker time to have the membrane position using external touches or using internal touches, and trying to diminish in our own way the trauma over the endothelium. So we have centered the graft on the previous PK. We inject this 20 or less % of SF6 as a regular basis, and then inject in the paracentesis antibiotics. Well, this is a little bit boring, the results you will see in the publication. The graph gives to you a little bit more idea. This is, as expected, a stable spherical equivalent in this particular group, as we regularly have in our Fuchs series. This is visual acuity recovery with quite tight standard deviation at 2 years. And this is the endothelial cell loss, which is quite similar to the standard series, at least for most of the published teams. So we had no episodes in this particular group of immunological graft rejection. Of course, that I have had graft rejection episode with different characteristics in the standard cases, so I presume that I will have in the future, but not yet. When I required intracameral layer reinjection, I presented this case last year in SICSSO, and I needed to open this tent after an immediate YAC membranotomy, which worked quite well, is the one that you can see here. Could you see that? Well, I would be able to surgically relift or reattach, but what I did is go with my patient with the area inside the eye, go to the YAC laser, just one shot, and it worked quite well in this eye. I presented this last year. We had one eye with artisan aphakic IOL implantation to correct the residual error, and another a sulcoflex explantation. And well, just a couple of additional cases. This is a 50-year, and the left one is a 50-year-old man who had full thickness transplantation in both eyes, 4 keratoconus on the 90s, ICL 99, re-PK, and clear lens extraction in 2003, visual loss, and DMEK. In fact, this is one of the first cases I did DMEK. I brought this because of the historical relevance, at least for me. I was still doing the technique injecting air in the front of the membrane to have it lying over the iris, and then take the air out from the anterior part and inject underneath. So it was the original technique. The other one, the right one, is a 49-year-old woman that, as you can read, is a PK for central scar, had AK and LASIK, toric pseudophakic IOL implantation in 2009, and then all of a sudden the graft failed. We did DMEK and worked successfully. This is a good example to see one of the, well, let's say that the refractive advantage. This lady had a significant number of surgeries only focusing in improving uncorrected vision. So to do a new full thickness transplantation would have been, particularly in this lady, a nightmare for a number of months. And this is the last vignette that I would like to share with you. This is a 68 years lady from Monaco who had a scar after post-traumatic infectious keratitis in full thickness in 2008, phaco in 2009, and toric ICL for residual astigmatism in 2010 in France, in Monaco. So vision was quite good, but she had a progressive visual loss that it was supposed, well, obviously, as you can see in the photographies in the upper side, the cornea was possibly because of a chronic endothelial cell failure, because she did not report any rejection episode. So we did our standard technique, center in the case. In those eyes with very deep chambers, it's slightly more difficult sometimes to perfectly centrate the graft, but well, finally we positioned the graft. But despite of a good surgery, a completely clear cornea, we still have vision improved a little bit from pre-op, but it's still a blurred image. And then we realized that it was not only the corneal problem, and it has happened in some other cases before, is that we had, as you can see here now with this retroillumination, a ICL anterior opacification. It's difficult for me to know because I have not the data and the pre-DMEK photographies. I wasn't aware of that because I gave the responsibility to, excuse me, it's not an ICL, it's a sulcoflex, excuse me. So So I don't know if this opacity in the anterior surface of the IOL was before the MEC, or it was induced because the air and gas in the anterior chamber, I don't know. But the fact is that this was the reason. Of course, you can take lenses out in several ways. You can use a larger incision, but I was quite confident that this was a myopic eye. The anterior chamber was deep enough to work, as I mentioned. It's more difficult for the MEC, but easier for this kind of maneuvers. So protecting with dispersive, constantly injecting dispersive viscoelastic, we simply extract the lens through a 2.2, again, in order not to induce any significant astigmatism, and clear image after the surgery, obviously with again, residual myopic error, which probably was the same that she had before she had this sulcoflex implantation some years ago. So in summary, I think that EK, in whichever manner you would like to work with, either the SICSSO, the DMEK, ultra-thin DMEK, new techniques for the MEC, but is the favorite surgical approach for most of us for failed PK, with a significant lower associated risk ratio and much quicker visual rehabilitation than the new full thickness. Obviously, compared long-term EC survival data is still lacking, but presumably will not be different than the one that we have with eyes without a previous full thickness. The MEC is my favorite approach. I was for a while doing the SICSSO in some difficult cases. This number of cases are diminishing, and I presume that for most the MEC surgeons is more or less the same. I am not doing the hematorexis. I am testing right now because I would like to see if vision may improve, making a small rexis inside the graft. Well, surgically speaking, is more or less the same. Results, for me, looks the same. Let's see, when we have more and more cases, it's sometimes difficult to compare groups of full thickness against full thickness. So it will be difficult, but at least it looks like that transparency on the center might be slightly better, and perhaps induction of aberrations is slightly better. What I do not like is to scrape the edges of the posterior wound. So perhaps doing in the center would be better. Thanks very much anyway for your attention.
Jose, can you comment on what DMEK tissue? Do you try and same size it with the PK graft, or do you make it slightly smaller?
Regularly, I try to have the same. But I think that the smaller might be a good option. I would not recommend to do it larger, although because of the same reason I do not like to grasp the posterior interface. But again, you know, then sometimes you talk with some other DMEK surgeons and says to you, well, I have no problems having a 9 millimeters, and I think that providing more cells is better, and I do not have any increased number of detachments. So what I'm doing is not because I have had complications doing a larger. I am doing this since the beginning because I think it's the best way to do. So usually the same size.
Yeah, with the SEC, it sometimes is an issue if the posterior shape of the cornea is disrupted at the wound. So I always found that with the SEC, it should be slightly smaller. With DMEK, it may not be such an issue.
Yeah, I think it might not, because if not, they would not say that. No, but still, I feel comfortable doing the same size.
Do you have any preference of age of the donor when you use tissues for doing post-failed graft? If you do a DMEK, let's say you get a 35 or a 40-year-old donor versus a 60-year-old donor, which one would you prefer for?
This is a good question, but not for full thickness, for any DMEK. So initially, we all preferred to use, and basically because of the surgical easiness, to use donors from 60 to 80, we'd say, no? But and I'm pretty sure that you have the same feeling. Today, if I have a 40-year-old donor, for all my cases, I love it. because once you surpass such a difficulty in on-rolling, yes, it will take perhaps a little bit longer, but I would prefer to work with 40 years old or 50 or 30 years old, despite that the roll is very tight, but I will take care of that. But so no, not particularly with PK. I always prefer to have younger donors.
One of the problems that I've seen doing fail grafts in DMEK is that the graft-host junction, usually if you see on the OCT, there is a protrusion internally. And if you use a DMEK graft, which is slightly oversized or you're not perfectly centered, one edge can be overriding the graft-host junction. And if you use a slightly younger donor tissue, that gives that little bit of irregularity. It gives an edge for that part of the graft to scroll. And especially if you're using air, which goes away much faster than using SF6.
Yeah.
So that can be a problem where that edge, if it scrolls, then you can have a partial detachment which may require a repeat rebubbling. So I usually prefer to use SF6 for all my failed grafts when I'm using it. And if I had to choose between a, let's say, 35-year-old donor on a 55, maybe I would use a 55-year donor for my failed graft rather than 35, knowing that the peripheral edge can maybe have a greater tendency to scroll.
I understand that point. The only moments where I decided and I look for an older graft are in those really hard, tough cases, such as
Post-tubes.
exactly, post-tubes, IC syndrome with tubes, with irregular, because then I will not have the easiness to use my techniques to reopen the graft. So.